In this class, we'll discuss about a disorder which is related to the myelin sheath, that is Guillain Barre syndrome. This syndrome is an acute condition which is an autoimmune one, acute autoimmune which is very severe and fulminant polyradiculopathy. We'll see the etiology of Guillain-Barré syndrome. Approximately 70% of cases will occur after 1 to 3 weeks of an acute infection, and this acute infection either it can occur in respiratory system or a gastrointestinal system. So whenever these two systems are having this infection, this infectious process will cause Guillain-Barré syndrome. And most of the infections are caused by Campylobacter jejuni. This is the frequent infections which can cause GBS. Next, human herpes virus, CMV, cytomegalovirus, Epstein-Barr virus, HIV, hepatitis E, Zika virus, and Mycoplasma pneumonia. These are the infectious agents which can cause Guillain-Barré syndrome, and some of the vaccines can also cause Guillain-Barré syndrome, that is swine influenza vaccine. Next is seasonal influenza vaccine, older type rabies vaccine, that is they use neural tissue, so they can cause Guillain-Barré syndrome. And recently SARS COVID-2 vaccine, especially those with adenovirus vectors, they can cause Guillain-Barré syndrome. Next, Hodgkin's lymphoma can cause Guillain-Barré syndrome, and systemic lupus erythematosus patients can also have Guillain-Barré syndrome. So we have seen the etiology. Now we'll see the pathogenesis. What is the basis for Guillain-Barré syndrome? So we can see Guillain-Barré syndrome in different subtypes. One is called as acute inflammatory demyelinating polyneuropathy, that is AIDP. Second one is acute motor axonal neuropathy, this is called as AMAN. Next is acute motor sensory axonal neuropathy. AMSAN. Miller-Fisher syndrome. And acute pharyngeal cervico-brachial neuropathy. These are the different subtypes which we can see in Guillain-Barre syndrome. Now, normally in the neurons we have gangliosides, and along with the gangliosides we have other glycoconjugates. These are present in large quantities in human nervous tissue. And in human nervous tissue, they are mostly concentrated at nodes of Ranvier. At this place, gangliosides and other glycoconjugates are present. We have GM1, GD1A, GT1A, GQ1B. So, these are GM1, GD1A, GT1A, GQ1B. This is gangliosides. These are other glycoconjugates which are present at the nodes of Ranvier. And in GM1, they are made up of galactose, N-acetyl, galactosamine, glucose, and N-acetyl nuraminic acid. This is the composition of all these glycoconjugates. This is the composition. But what is the difference between these four types of glycoconjugates? Number of N-acetyl nuraminic acids are different in each of these glycoconjugates. So GM1 has only one N-acetyl nuraminic acid, that is called as a NANA. And GD1A has two N-acetyl nuraminic acid. GD-T1A has 3 N-acetyl nuraminic acid. GQ1B has 4 N-acetyl nuraminic acids. These nuraminic acids are attached at galactose. And all these things will have one more common thing, is ceramide. To this ceramide, galactose, N-acetyl galactosamine, glucose are attached, and to this galactose, N-acetyl nuraminic acid is attached. Okay, this is about gangliosides. Then what is the importance of these gangliosides in Guillain-Barre syndrome? That there is a circumstantial evidence. There is no particular evidence such that what happens in the GBS. So, the circumstantial evidence suggests whenever there is an entry of infectious agent, there will be an immune response. Suggests that all GBS subtypes results from, that is Guillain-Barre syndrome results from immune response to non-self antigen. That is, it can be due to infectious agent or it can be due to vaccines. This causes this immune response will be misdirected to host nerve tissue. Why there is a misdirection to the nervous tissue? Because there is a resemblance of human tissue to the epitope. Resemblance of epitope to the human tissue. Okay, this host nerve tissue resemblance to epitope of an infectious agent. So there is a molecular mimicry. That is, both human tissue and infectious agent will have similar kind of epitope. So the immune response is directed towards the host tissue and infectious agent, and they will cause a immune reactions. What happens here when there is an immune reaction? Immunoglobulins are secreted. That too, IgG autoantibodies are directed against GM1 or GD1A. When these GM1 or GD1A are attacked by these autoantibodies, we will get acute motor axonal neuropathy and acute motor sensory axonal neuropathy. And whenever IgG autoantibodies are directed to which one? GT1A. Not GT1A. If it is directed to GQ1B, and they will have a cross reaction with GT1A. So first autoantibodies are directed towards the GQ1B, and there will be a cross reaction with the GT1A also, and they will cause this type of autoantibodies will cause Miller-Fisher syndrome. That is, autoantibodies to GQ1B will cause Miller-Fisher syndrome. When IgG autoantibodies, when they are directed to GT1A, and there will be a cross reaction with GQ1B, then we will get a subtype Guillain-Barre syndrome, that is pharyngeal, cervical, brachial weakness. So this Guillain-Barre syndrome is due to formation of autoantibodies to the human nervous tissue, that is especially to the gangliosides and other glycoconjugates. And we can see IgG antibodies to GM1, and this can cause AIDP, that is acute inflammatory demyelinating polyneuropathy. Acute inflammatory demyelinating polyneuropathy, AIDP. Next, we will see the sequence of events how this damage of myelin will occur in Guillain-Barre syndrome. First, what will happen? Antibodies are directed towards the nervous tissue where there is an recognition of the own nervous tissue as an antigen, and they will bind, antibodies bind to the antigen, and they will cause complement activation. This complement activation will cause formation of membrane attack complex, where they are formed on the outer surface of Schwann cells. What is the function of Schwann cells? They help in formation of myelin, and this causes damage of nerve, and due to the formation of membrane attack complex and damage of the nervous tissue, there causes recruitment of macrophages. These macrophages will invade myelin, and as myelin is damaged due to the membrane attack complex, this is due to the activation of complement system, this damaged myelin is removed. So macrophages will remove myelin debris. This is what will happen in the Guillain-Barre syndrome. This removal of myelin debris will cause demyelination of nerves. So myelin will be lost, which is surrounding the axons. So these gangliocytes and other glycoconjugates are expressed at the nodes of Ranvier. At nodes of Ranvier, so this GM1 and GD1A, they are concentrated at nodes of Ranvier. So at nodes of Ranvier, we also have voltage gated sodium channels. Okay, this antibodies to GM1 and GD1A will cause this damage to the GD1A and GM1 will cause damage to voltage gated sodium channels also. If this voltage gated sodium channels are damaged, and there will be nerve conduction failure. If voltage gated channels are damaged, then there will be nerve conduction failure. That is, action potential cannot be generated, and patient will have muscle weakness. This is the cause of muscle weakness in Guillain-Barre syndrome. Now we will see the clinical features. The most important thing is that we have to keep in mind is fever and constitutional symptoms are absent at onset of GBS. This is the main feature. Okay. Apart from that, we can divide this Guillain-Barre syndrome symptoms into motor type, sensory, and autonomic. So these systems are affected. We'll see first motor symptoms. What happens? Which thing will happen in motor system? This is a rapidly evolving motor paralysis. The paralysis will be very rapid. And what type of paralysis is it? This is an ascending paralysis where limbs are affected first and the legs will be like rubbery. They'll not have any power. They'll feel like a rubbery thing. So patient will have rubbery legs. They will have ascending paralysis and there won't be any reflexes. So areflexic. And this weakness will evolve over, that is, weakness will evolve over hours to few days. And patient will have facial weakness, that is called as diparesis. This facial weakness is seen in 50% of GBS patients. And bulbar muscles, lower cranial nerves can be affected and they will cause bulbar weakness. Due to this bulbar weakness, they will cause difficulty in swallowing and there will be difficulty in speech also. We can see respiratory paralysis. And this respiratory paralysis will be life-threatening. And deep tendon reflexes are absent. And sphincter tone will be normal. These are the motor symptoms which we will see in Guillain-Barre syndrome. In that ascending paralysis, we have to remember that patient will have an ascending paralysis. Next, sensory symptoms. This sensory disturbance may or, that is, sensory disturbance may or may not be present. Like cutaneous sensations, that is cutaneous sensory deficits like loss of pain and temperature are mild. These sensations are not that much affected and patient will have tingling dysesthesias. Slight touch, the touch will also cause severe pain in the extremities. So tingling dysesthesias in extremities. The normal response will be abnormal in these Guillain-Barre syndrome patients. And this can be a prominent feature. It's prominent sensory feature. And bladder dysfunction is uncommon. Dysfunction is uncommon. That is, normally it is not seen. If it is seen, that too only in severe cases. Severe cases. If this bladder function is the prominent feature, then you have to think about other diagnosis. It can't be GBS if bladder dysfunction is a prominent feature. Next, autonomic. These autonomic symptoms are common. We can see even in mild cases. We can see in mild GBS also, Guillain-Barre syndrome. What happens when autonomic nervous system is affected? Patient will have wide fluctuations in blood pressure. Patient will have postural hypotension. Patient will have cardiac dysrhythmias. Arrhythmias can occur in these patients, and these can be life threatening. These have to be closely monitored in a Guillain-Barre syndrome patients. And patient can have neuropathic or radicular pain. And this is present in many patients. Next, these are the features which we will see in the Guillain-Barre syndrome. And we have talked about Miller-Fisher syndrome. What happens in the Miller-Fisher syndrome? What symptoms? So it is a triad. We can see triad of symptoms. What triad? That is ophthalmoplegia, ataxia, areflexia. And this ataxia and areflexia is can be without weakness also. And in ophthalmoplegia, there will be pupillary paralysis. So these are the three clinical features which are seen in Miller-Fisher syndrome. And we have a criteria that is called as Brighton criteria for a diagnosis of Guillain-Barre syndrome and Miller-Fisher syndrome. Next, we'll see laboratory findings. For laboratory thing, cerebrospinal fluid is very important. Cerebrospinal fluid estimation is important. What happens in the cerebrospinal fluid? Patient will have elevated CSF protein, and they will have normal cell count, that is less than 50 cells per microliter. So this is the diagnostic criteria for GBS. This is called as albumin cytological dissociation. This is the term which is given for this variation. That is, only elevated CSF protein will be seen and cells are not increased. And it will take up to 2 weeks. To develop these changes. In the initial phase of the Guillain-Barre syndrome, there won't be elevation of protein and there won't be any change in the CSF. It will take 2 weeks. And you have to remember that if cell count, that is WBC, it is greater than 50 cells per microliter, then you should think of alternative diagnosis, that is viral myelitis. You have to think about viral myelitis whenever cells are increased. So this is a classical laboratory finding, and you can do electrophysiological studies on nerve conduction. Early features, electrophysiological features, and we have in the late disease and in early disease. We have different scenarios. That is, in early, there will be prolonged F wave latencies, prolonged distal latencies, there will be reduced amplitudes of compound muscle action potential. The amplitude is very less. Whenever disease is early, these are the features we see when we do nerve conduction studies. And in late stages, what will happen? There will be slowing of conduction velocity. There will be conduction block. And there will be temporal dispersion. That is, what is temporal dispersion? There will be an increase in the difference between the conduction times along the different axons. That means different axons within a nerve will have different conduction times. So each axon will have different conduction. This is what we see in a Guillain-Barre syndrome. These are the investigations we will see in the Guillain-Barre syndrome. So next is treatment. You should not wait for the laboratory findings, because this is a rapidly progressive disease. If you are sure about the symptoms which are related to the Guillain-Barre syndrome, then you have to start treatment immediately after diagnosis. So it should be initiated as soon as possible, because each day counts. Each day counts, and the paralysis will go on increasing. That is an ascending paralysis. The paralysis will go on increasing and it will affect the patient. And treatment may not be effective if initiated 2 weeks after first motor symptom. Treatment is not useful. So early treatment is more important. You can treat this Guillain-Barré syndrome with IV immunoglobulins, or you can do plasma pheresis. This is called as plex. You can either treat with IV immunoglobulins or plasma pheresis. Both are equally effective. Combination of these IV immunoglobulins and parapheresis, there is no advantage. There is no advantage. And in Guillain-Barré syndrome, the patient will reach a plateau stage. That is, there is no increase in or worsening of a condition. It will reach a plateau stage. So, when patient has already reached plateau stage, treatment is no longer indicated. It is no longer indicated. And you have to remember that in Guillain-Barré syndrome, glucocorticoids are not effective. This is the thing you have to remember. Glucocorticoids are not effective. Next, you have to give supportive therapy. You have to manage in ICU, critical care setting, and you have to check vital capacity, because in Guillain-Barré syndrome, patients will die due to pulmonary complications. You have to monitor heart rhythm, because autonomic symptoms are life-threatening things. So you have to monitor blood pressure. If blood pressure is decreased, you have to give pressors and chest physiotherapy to decrease pulmonary symptoms. You can do tracheotomy when needed. You have to give thrombosis, because patient will be resting on the bed continuously and there is a chance of DVT. You have to give thrombosis prophylaxis, which is very important in Guillain-Barré syndrome. Next, these are the treatment part. This is the treatment part. Next, what will be the prognosis and recovery? 85% of patients will recover, and there will be a full functional recovery. Some patients won't recover, and this recovery will take several months to years. And 20% patients are left with persisting disability. That motor weakness will stay like that only. And in between 5 to 10% of patients, they have clinically similar relapses. Relapses. That is, the disease will repeat. It can be one or more times. This relapse can be one or more times. This is about Guillain-Barre syndrome, which is related to myelin. In this Guillain-Barre syndrome, myelin sheath is damaged due to formation of auto antibodies towards the gangliosides or other glycoconjugates which are present in the nervous neurons, especially at the nodes of Ranvier. This is Guillain-Barre syndrome. This is about in detail thing about Guillain-Barre syndrome. Thank you.